I first want to thank everybody for being here. I want to thank Dr. Anderson for the invite to come and speak to you today. As you mentioned, I'm from the University of Colorado, and we're going to be talking about imaging in soft tissue tumors. I have no disclosures, and I'm just going to be really honest. Soft tissue tumor imaging is hard, and I see residents really shying away from the cases altogether. I see most fellows hedging. They throw every possible soft tissue tumor they can think of into this differential. And honestly, I see most attendings really oversimplifying or being very non-committal with their soft tissue tumors. Like there's a case that the indication was soft tissue mass and the impression was soft tissue mass in the anterior forearm. That's obviously not particularly helpful. So in order to make this easier on ourselves, we have to understand why this is so hard. Now, these are excerpts from Mark Kransdorff's book, kind of illustrating just how extensive the soft tissue tumor differential can be. And it gets very overwhelming, and I find that a lot of people are overwhelmed by what I call the prefix salad. You get all of these prefixes and they kind of haphazard throw them together, and then you've got a new tumor, and that can be very overwhelming, and we sort of shut our brains off and go, you know what, I'm never going to know them all. I just give up. But in reality, all we have to do is really pare it down. We have to eliminate the clutter, and we have to focus on what we actually can achieve here. What are we going to see clinically? And almost, just as important, what can we actually say by imaging? So let's try to be helpful when we can. So I'm going to start off with an intro to soft tissue tumor imaging, talk about imaging modalities and techniques, and lead that right into an algorithm of soft tissue tumor assessment. And then we'll get into the meat of the talk. How can we be helpful as radiologists while maintaining our accuracy? And we're going to talk about this in two categories: sarcomas in general, which is what I call sarcomas NOS, or big bad sarcomas. How do we identify those? What features are we looking for? And then we'll get into the subtyping of tumors. And these are the different subtypes of soft tissue tumors. I'm not going to talk about muscle, which is your leiomyosarcomas, your rhabdomyosarcomas, and I'm not going to talk about vascular. It's just the bad tumors in these categories. They don't really have a lot of specificity to the imaging. And then benign vascular tumors is just kind of too broad a topic. So we're going to exclude those for now. So when we approach soft tissue tumor, it's really important that we get a good clinical presentation. If we're doing an ultrasound, we can ask the patient. If not, we need to go to Epic. Is this lesion painful? How long has it been there? Is it growing? What is the background of the patient? Do they have any underlying conditions? It's reasonable to start with a radiograph. This can tell us if there is a clear skeletal explanation, like an exostosis. Maybe they've got some hardware that's pulling out. It can also tell us if we've got associated calcifications, which is actually very important. We're going to talk about that more in a minute. And then, of course, if there's a clear fatty component, it can give us an indication of that as well. Ultrasound is great at confirming the mass. Sometimes we feel things that honestly aren't really there. So is there really a mass there? Is it clearly cystic? Is it clearly a lipoma? It can also help with biopsy guidance. Now, there's a lot of new literature out there on elastography. I feel like we keep trying to make this a thing. If you do it, great. We don't. Maybe I'm just biased because we don't do a ton of it. But there is new research out there that shows that malignant lesions are more stiff than benign lesions, and it has a decent sensitivity specificity. Honestly, I think personally that MR is probably a little bit easier to interpret. So this is our gold standard in soft tissue imaging. It's the best chance at characterizing the cellular subtype, and it may offer insight into a benign or malignant lesion. So how do we approach soft tissue tumors? Well, we have a mass. Reasonable to get an x-ray. Does the x-ray clearly answer the question, is there a big osteochondroma like we can see here? Yes, great, we're done. No, ultrasound is a fine next step. Is it clearly a cyst? Is it clearly a lipoma? Yes, great, PRN follow-up. No, well then we're going to MRI. And I'll tell you probably about half of the soft tissue tumors that we look at are going to end up going for that MR assessment. So the MR protocol should include all of your standard protocols. Of course, we're going to add contrast unless it's contraindicated. But the other thing that we need to consider is getting a T1 pre with and without fat saturation. The reason being, we want to see if there's any intrinsic T1, like we can see here, a little bit of hemorrhage. Maybe there's a little bit of intrinsic T1 there. and contrast that to our post, where we see no enhancement in that area, and enhancement in the more cellular component. So it basically gives you the benefit of knowing for sure that something is truly enhancing. FGG PET isn't used in the initial assessment. That's per the ACR appropriateness criteria, but it is potentially very useful in staging high-grade soft tissue sarcomas, particularly when we get into malignant peripheral nerve sheath tumors, which we'll talk about here in a minute. Okay, so let's get into the meat here. How can we be helpful as a radiologist? And we're going to start again with soft tissue sarcomas. So soft tissue sarcomas make up the vast majority of malignant soft tissue tumors. There are multiple subtypes with various degrees of dedifferentiation. There is an age predilection in the peripheral body. Take this with a grain of salt. This is my breakdown here. Obviously, there's a lot of overlap. But in our older patient population, UPS, or undifferentiated pleomorphic sarcomas, are common. So are liposarcomas and leiomyosarcomas. In our younger adults, we want to think about synovial sarcomas, particularly our male patients, but fibrosarcoma and angiosarcoma are also decently common. In a child, you're going to get that rhabdomyosarcoma, lipoblastomas are also common, fibrosarcomas, and angiosarcomas. Okay, so undifferentiated pleomorphic sarcoma is basically just means these cells are so dedifferentiated, we can't actually subtype any of them. So any other sarcoma can morph into a UPS, and high-grade subtypes can appear identical when they get very dedifferentiated. So I have a bucket, and I talk to residents about this a lot, this sarcoma not otherwise specified, sarcoma NOS, big bad sarcoma category. You have to allow yourself the right to not know. And I think that's a lot of our problem as radiologists. We don't like to not know, but it's okay if you have a sarcoma that's so dedifferentiated, you're not going to know the subtype, and just call it a sarcoma and put it in what I call the sarcoma NOS bucket. And that's completely fine to do. So what are we looking for in our big bad sarcomas? Well, they are typically ovoid in shape. That's actually very important. They deposit and they just grow out, so they maintain that rounded configuration. They are very ugly looking. They are very heterogeneous on the T2. They are very heterogeneous on our post-contrast imaging, and they often outgrow the blood supply, so you see these areas of central necrosis very frequently. The other thing that's interesting about soft tissue sarcomas is that they don't tend to invade. They are very aggressive tumors, but they tend to push. So you'll see that sarcoma pushing that muscle away, pushing the soft tissues away. In high-grade lesions, you'll see more central necrosis. You'll see more of that peritumoral edema. Okay, so now let's get into some of our subtyping. And again, these are the subtypes we're going to talk about, not muscle or vascular, and we're going to start with fat. So our lipomatous tumors. In each of these subtypes, I'm going to talk about key imaging features. So what are the imaging features we're looking for to know that this is the subtype of the tumor? In fat, obviously on CT, we're looking for low density. On MRI, we're looking for that high T1 signal with fat saturation. Our benign fatty tumor, everybody knows this, is a lipoma. It's the most common benign soft tissue tumor. It's frequently in the neck or in the back. It's slow growing, it can be multiple, and it's usually small. 80% of them are less than 5 centimeters, but that means 20% of them are larger than 5 centimeters, and even 1% are greater than 10 centimeters. We're going to talk about that more here in a minute, because I think that's an important point. So on CT, what we're looking for is fat attenuation that is less complex than the subcutaneous fat. Now, this is a very important feature. Lipomas tend to be less complex, less septation than the subcutaneous fat. This is basically what's going to cinch that diagnosis of a lipoma for you. And it may or may not be encapsulated. Look at this one. Very hard to see there. Maybe there's just a little tiny, very thin capsule, but they can be very difficult. On MRI, it's going to follow fat signal on all the sequences. We're going to have high T1. It's going to saturate out. We don't want to see any nodular or septal enhancement. And again, it may or may not have encapsulation. Look at this one. So this is so simple. You can actually see it because of the simplicity. It's actually pushing away some of the septations in the normal fat. So let's talk about this size criteria thing. So what about this lesion? This lesion here in the back is larger than 5 centimeters. And some people would say, well, if it's greater than 5 centimeters, you got to call it a well-differentiated liposarcoma. I don't really want to call this a liposarcoma, and I don't know if any of y'all do. So if you look at individuals who know soft tissue tumors even better than me, like Mark Murphy in the AFIP, he doesn't use size criteria. He says, if you can convince yourself that the complexity of the lesion is less than that of subcutaneous fat, that is all you need to call it a lipoma. He doesn't care how big it is. He says if it's more simple, there's no way that that's going to be bad. Similarly, deep lesion. So here's a lipoma in the psoas. It's much simpler than the subcutaneous fat. We should be fine to just call that a lipoma. How about this lesion? It's a deep lesion in the forearm, but look at the simplicity of the fat. Again, similar to slightly less complex in the sub-Q, no internal enhancement, that's going to be a lipoma. Ultrasound can be very helpful. Again, cysts and lipomas are the only time we can really make a differential of soft tissue tumors by ultrasound. You're going to see echogenicity very similar to subcutaneous fat. It's going to be uniform and avascular. I loved this one because it's so similar to that sub-Q fat. You can see this oblong lipoma around the elbow, identical to that subcutaneous fat. So I liked this. This is from a lecture that Dr. Murphy gave. He calls it Murphy's Law. If the indication is soft tissue mass and you don't see one in the first 5 seconds, it's a lipoma. And I think that's a really good point. I've come across this all the time. Like, I don't see anything. Like, look at this one. Who knows? But just kind of turn on your radar. Look for that unencapsulated lipomatous tumor. So what about when it goes bad? What about the malignant subtypes? Atypical lipomatous tumor and liposarcomas. These are typically in our older patient population, pelvis and thighs, the most common. And then we have this whole subcategory of ALT, or atypical lipomatous tumor, which is synonymous with a well-differentiated liposarcoma. So an atypical lipomatous tumor is made up of predominantly fat. It has to have more than 75% fat to call it an ALT. It has to have thickened septations of more than 2 millimeters, so something like this, and they tend to be larger lesions. What about this one? So here we have a pretty large lipomatous tumor. That's going to measure definitely more than 5 centimeters. It's deep. It's underneath that triceps. Is anybody going to call this a ALT or well-differentiated liposarcoma? Are you going to call this a lipoma? So this is kind of the no man's land. This is where we get a lot of debate. I think based on what I have heard in lectures, again, people smarter than me, this is one that we could reasonably call a deep lipoma and leave it alone versus a well-differentiated liposarc. In reality, they're going to be treated generally pretty similar. Most surgeons are not going to go in and do a massive resection on something that looks so simple. How about this one, though? Also a big lesion, deep to the deltoid. This one's harder for me. Maybe it's a little bit of, has a little bit more septation than the subcutaneous fat. This one, I think, is that gray area. You might go atypical lipomatous tumor on this one. And then this one shouldn't be a mystery. This is clearly a well-differentiated liposarcoma, very thick septations, areas of enhancement. I don't think anybody's going to call this a simple lipoma. All right, how about our very high-grade liposarcomas? Well, here we have a fatty component you can see with the arrow on the first T1 image that saturates out on the T2, and we have this nodular component that's very complex. Low T1 signal, very heterogeneous on the T2, and a lot of central necrosis on the post. Okay, this is the one little prefix salad sidetrack I'm going to take, I promise. The myxoid liposarcoma. This one is actually important for us to know because we can identify it and we see it frequently. So a myxoid liposarcoma simply means it has myxoid components, and myxoid is basically like jelly. So we see this T2 bright component, and we may also see that T1 bright component of the fat. We can make this diagnosis, and it's pathognomonic by imaging if we see that fatty component, but sometimes we don't. So let's take this case, 55-year-old male with a thigh mass. This is all we've got here, this little bit of high T1, but it does saturate out. So it is fat. There is macroscopic fat in this lesion. there's a ton of high T2 signal and this wispy, kind of hazy, unimpressive enhancement. That's the myxoid. So that's what's going to make this diagnosis of a myxoid liposarcoma. They don't always look that way. This one looks gross. This one's going in the bucket for me, just sarcoma NOS. The other thing about a myxoid liposarcoma that's important to realize is that PET is insensitive. So look at this lesion. This is a little bit higher up on the lesion, but that's the only spot of FGG avidity in this entire lesion. So you have to get a whole body MRI if you're looking for METs in this case. So let's talk about pitfalls. This is a crazy case. I stole this from Mark Kranzdorf's book. This is muscle infiltration of a lipoma, where you see all of that fat interweaved in the fibers of the muscle. This is actually a sign of a benign lesion. This is a lipoma. If you can convince yourself it's infiltrating the muscle, it's benign. And that kind of blew my mind when I heard the lecture talking about that. But I think that's a good thing to remember. It'll save us some headache. The other thing is a periosteal lipoma. I've seen these called, oh my gosh, like osteosarcomas, liposarcomas, because they can have a lot of osseous components to them. But the osseous components in a periosteal lipoma tend to be very well defined. They look very benign. And basically what this is a lipoma that involves the periosteum. It pulls the periosteum off, and you get these stalks of bone that extend into the lesion. This is an Ant-Mini diagnosis. This should always be called periosteal lipoma. There's nothing else that this can be. And finally, a hibernoma, which can be a very complex imaging appearance, typically occurs in males in their 20s and 40s. It makes up less than 1% of fatty tumors. It's made up of brown fat cells. And the imaging is an encapsulated heterogeneous mass, hypo to iso intense to the subcutaneous fat, and mildly increased T2 signal and enhancement. We think about hibernomas a lot when we look at PETs because they're very, very PET avid. But here on the CT, you can clearly see that this is a fatty tumor. So we shouldn't get confused with that avidity and call it a liposarcoma. Here's just a crazy case of a huge hibernoma, hypo to iso on T1, no fat saturation, and mildly hyper on the T2. But look at this enhancement. It's so unimpressive. So this we should be considering a hibernoma rather than any liposarcoma. Okay, so let's move to our fibrous tumor subtypes now. Fibrous material on an MRI, think about fibrous materials that we know, like a meniscus or a tendon or a ligament. The signal in that fibrous component is going to be low on T1 and low on T2. That's how we know it's fibrous, kind of like a scar. It's also going to have a non-enhancing component to it. But maybe one of my favorite features of fibrous is that it has this creepy, crawly growth. Other things don't really do that. They tend to grow in a rounded way. Fibrous will creep along fascial planes, and we're going to talk about that more here in a minute. So what is a benign fibrous tumor? It's a fibroma. This is a slow-growing mass, typically in the plantar fascia, but you can also see it in the palm. As well, here's a typical plantar fibroma. You can see these areas of low T1, low T2, fibrous material scattered throughout this lesion. But most importantly, its location here. It's located in the aponeurosis of the plantar fascia, cinching that diagnosis. Now, look at this case. This shouldn't confuse anybody. We can see these being very highly cellular. Look at all that T2 signal. Look at all that enhancement. This is still a fibroma because it's located within that plantar aponeurosis. Here's just a case of Dupuytren's fibromatosis. You can see those areas of low T1 and low T2 in that palmar aponeurosis. Okay, so how about desmoids? Desmoids are also benign, but they're locally aggressive. We see these very frequently, and it's important that we know how these behave. We basically are looking for variable degrees of non-active fibrous components and active cellular components. We're also going to see that creepy, crawly growth along fascial planes and sometimes some extension to the dermis. So here's a desmoid tumor. You can clearly see those areas of low T1, low T2, that's fibrous, with this central area of more cellular makeup. Look at this here. This is where we see that creepy, crawly growth along the fascia. Again, sarcomas of other subtypes are not going to do anything like this. This is a feature of a fibrous lesion. Here's another example of desmoid fibromatosis, dark, non-enhancing fibrous scar surrounded by a cellular component that creeps and crawls along the fascia. Okay, how about our malignant subtype, fibrosarcomas? This is a small subtype of sarcomas, but it's typically our younger patient population. It can really be in any location, but we're still looking for either low fibrous elements or that flattened, creepy, crawly growth. Here's an example of a fibrosarcoma. Look at this lesion here. Look how extensive it is. It's so long. It's just growing along that superficial fascia. Here you can see those fascial tails as well, and it's involving some of that superficial fascia aponeurosis there as well. What about this one? Ugh. This one's just big and gross. This was a fibrosarcoma also, but it's very lobulate. It's behaving very much like a dedifferentiated sarcoma. This is oftentimes where these fibrosarcomas are going to go. We may not see these areas of fibrous makeup in here, but this is going to be a hard one. It may just go into the sarcoma NOS bucket as well. And then lastly on the fibrous tumor, I want to talk about DFSP or dermatofibrosarcoma protuberans, because this is usually a pretty easy diagnosis to make. So this lesion arises in the dermis, which gives it the protuberant feature, meaning it's very exophytic, it's very big, it's growing out of the skin. These have a pretty good prognosis, actually. So the one pitfall I want to talk about with fibromatous tumors is nodular fasciitis. Man, I struggle with nodular fasciitis. I think it is an incredibly hard tumor to evaluate. It's a very common benign tumor. It's usually in young adults, and it's usually upper extremity. And I would really focus actually on that predilection for the upper extremity. I don't think I've ever really seen it in the lower extremity. It loves the spots around the elbow, the upper arm, the forearm. It may mimic malignancy, though. These things can get really, really gross looking. Here's a little one. The good news is these are pretty painful, so they often present as little lesions. If you see a little lesion like this in the forearm or around the elbow that's super painful, think about nodular fasciitis. That's probably what it is. Little lesions like this don't typically hurt. So if it is painful, probably this. You can get a sense of a nodular fasciitis because it does, again, demonstrate that fibrous tail along the fascia. You can see that a little bit here on the post-contrast imaging as well. So this one, I think we have a decent chance of making the diagnosis. This one from the literature, that's pretty big and gross. That makes me a little bit uncomfortable. I think I'd probably go for biopsy there. And this one from our institution was just really difficult. This was around that radiobicipital bursa. You can see this very heterogeneous T2 lesion, tons of enhancement in this thing. Maybe you could argue that the degree of inflammation is way too much for just a regular sarcoma, but this one actually went for biopsy and was found to be a nodular fasciitis. So just keep that in your differential list. Know that these things can be ugly, but also know that it's okay to send these for biopsy because often that's what we'll need. Okay, let's get to our neurogenic tumors here. Neurogenic tumors have features basically, if it's along a nerve, that's how we're going to know it's a nerve tumor. There are multiple subtypes you can see here. We're going to focus on the benign peripheral nerve sheath tumors in our benign category. So peripheral nerve sheath tumors make up about 12% of benign soft tissue masses, so they're very common. And what we're looking for is a mass along a nerve. Is there a nerve running into the lesion? That's what's going to tip us off that this is a neurogenic tumor. You also have several signs that we'll talk about here in a minute, tend to be very bright on T2 and tend to have fairly uniform enhancement. So let's take this lesion. This lesion actually demonstrated all three of our signs. So we have the split fat sign, which is where you see this kind of fat tenting on the upper and lower margin of the tumor. This is because nerves have to be protected by fat. So anytime you have a nerve tumor, it's going to push that protective fat away. And so you're going to get that split fat sign. The entering exiting sign is simply saying there's a nerve going in, there's a nerve going out. This is probably the most specific and sensitive sign. And then you have something called the target sign, which has to do with this highly cellular central component and a more myxoid peripheral component that gives you a target type configuration. Here's a smaller lesion. This was a peripheral nerve sheath tumor, but it shows you how subtle but present that target sign can be. I really like the target sign. I find it to be a pretty reliable imaging feature. And then ultrasound can be helpful, but sometimes these things can look pretty ugly and complex. This was one that we felt pretty confident we could see the ulnar nerve running into this lesion, so we called it a peripheral nerve sheath tumor. So what about our malignant subtypes, which is going to be a malignant peripheral nerve sheath tumor? This is about 10% of all soft tissue sarcomas, very highly associated with NF1. And what we're looking for is a larger lesion. It's oftentimes very ugly looking. And if it's in a peripheral nerve, like the example here, I don't think we have much of a chance of saying this is a malignant peripheral nerve sheath tumor over any other sarcoma. If it's along a big nerve, like the tibial nerve or something, maybe we do. But in general, these look just very ugly and inflammatory. The best chance we have is if we have a patient with NF1 and we can show rapid enlargement of an existing neurofibroma, and that's where PET can be particularly helpful. So I'm just going to show you a couple examples of a malignant peripheral nerve sheath tumor just to illustrate how big and junky these things can look. Here's another example in the brachial plexus. Lots of central necrosis, PET avidity. So looking just like any other big bad sarcoma, probably going to throw this in the bucket and get a biopsy. Here's a neurofibromatosis 1 patient. You can see these plexiform neurofibroma. I want to draw your attention here to this psoas lesion. Patient came back a couple years later. Obviously, this thing has gone bad. So if you have any question in a neurofibromatosis 1 patient, send them for a PET. The PET avidity can help you differentiate. There's a lot of literature out there on that. This one shouldn't be a diagnostic mystery for anybody. Okay, my favorite subtype, and we're just about done here, is myxoid. So what is a myxoid subtype? We talked about this being this jelly donut type of component, this very, very high in T2 signal because it has a very high water content. And it has very hazy enhancement because it's not particularly cellular. And we'll talk about this T2 capping, which is one of my favorite findings in soft tissue tumor evaluation. So our benign lesion is an intramuscular myxoma. That's the only one that really exists. So an intramuscular myxoma, like the name implies, has to be intramuscular. It's typically ovoid, and it has a very thin, porous capsule, which is going to explain why we get this really awesome imaging feature of the T2 cap. So take this myxoma sitting here in this muscle. Let's say you contract that muscle and squeeze this jelly donut. It's going to ooze out this myxoid material through that porous capsule, but it's always going to be along the axis of the muscle. That's the only place that it's going to go. That's why we get the cap. So let's look at this example. Super bright T2. Look at that T2 cap along the axis of that adductor muscle. And look at how wispy and unimpressive this contrast enhancement is. Here's another example. Very high T2 signal, wispy, unimpressive central enhancement. And then we've got that proximal and distal T2 cap because of the insufficiency of that capsule. This is just a fun case. Multiple intramuscular myxomas. We've got some T2 capping in a patient with fibrous dysplasia. This is something called Mazabrod syndrome. Okay, well, what about malignant? Well, this is only a subtype. A myxoma cell can't really become malignant. It's too acellular. So there's no myxosarcoma. It has to be attached to something else. We already talked about the liposarcoma. You can also get myxoid fibrosarcomas. Typically just look like big bad sarcomas with this high T2 myxoid component that doesn't enhance that well. So that's how you're going to know that it has a myxoid subtype. I don't know that I often say that this is, probably a myxofibrosarcoma. But if you do see this, I think it's reasonable to at least consider it. We do have that creepy crawly growth that's kind of tipping us off that this is a fibrosarcoma. Similarly here, high T2 signal, there's that area of non-enhancement, which is the myxoid component, and this creepy crawly growth along the fascial planes. Okay, in the last minute, we're going to talk about synovium as a subtype. All I want to talk about is the malignant subtype, the synovial sarcoma. This is basically a big bad sarcoma. It's going to look ugly. It's going to look heterogeneous. It's going to be near to, but not inside, a joint, and it's going to potentially have these punctate scattered calcifications. This is a lesion that happens in young males. It's usually in the extremities, and it does have a little bit of a higher propensity to hemorrhage. look at this lesion. So 37-year-old male with enlarging thigh mass. He came in just for a radiograph. This is all we see, which is terrifying. This little punctate calcification, got the MRI. Here we can see the more complex, typical sarcomatous mass, ovoid, heterogeneous T2, heterogeneous enhancement. In this patient population, especially with that calcification, synovial sarcoma is where we're going to go. Here's another synovial sarcoma. You can see the cellular component here enhancing on the post-contrast imaging. This was one that had bled. So we can see that non-enhancing blood products. You can actually see that hematocrit level on the T1 and the T2 weighted imaging. So I just throw a couple more radiographs on here because I can't emphasize the importance of being able to pick up this finding on a radiograph in this young patient population. A couple of examples of what those punctate calcifications can look like. Obviously, this is a pretty big mass, but tiny little calcifications. This one has a little bit more extensive calcifications, but they generally appear very scattered, very unorganized. Okay, so we've talked about the algorithm of an imaging protocol for soft tissue mass evaluation. We talked about the features of sarcomas NOS: ovoid, heterogeneous, necrotic, pushes, doesn't invade. Know that it's okay to not subtype. Calling something a soft tissue sarcoma and putting it in that bucket is completely fine. And then if we're able to subtype, fat, fibrous, nerve, myxoid, synovial are our best bets for differentiating, and probably more importantly, being able to differentiate those benign versus malignant lesions. So thank you so much for your attention and for kind of powering through for soft tissue tumors.